We are doing a anterior cervical Deuk laser disc repair. This is a transdiscal endoscopic surgery. Go ahead and take a shot. We're in the middle of localizing to the C6-7 back to a lateral. We're going through the front of this patient's neck. We're going to be doing endoscopic surgery, and we're going to repair 2 disc herniations. All right, we need you to pull. We're going to be repairing 2 disc herniations, one at C5-6, the other at C6-7. That's perfect, guys. Relax. Everybody relax. I'm very happy with where we are. Relax. Everyone relax. All right, so the surgery is done through the front of the neck. It's endoscopic. We'll be using a 4mm incision, the smallest surgical incision in the world, to do a discectomy through the front of the neck. We're going to do this endoscopically. I need a pull and a shot. We just did a discogram. I've injected some dye. I want to take a look at the internal architecture of the disc. I'm looking for abnormalities. I need a little more. You know what, Luis? I might be able to do it. Let me hold. Let me do it. Shot. There we go. That looks good. All right, so you can see the needle is in the center of the disc, and we're going to be using that as our starting point. I'm going to introduce the guide wire now that I've done the discogram at C6-7. I will need to see lateral views, so you can come lower and get more penetration. Luis, go ahead. I need a little bit more.
Thank you.
Pull a little harder. And perfect. That's good right there, everybody. Just hold. You relax. You relax. You relax. 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 Everybody relax. We got the picture we needed. So I'm using a lateral view to see exactly where we are in the disc. Take this. Now this is state-of-the-art surgery. You're not going to find this done anywhere else in the world except Korea, maybe China now. There's no one else in the United States doing this surgery. It's the future of spine surgery. Spine surgery can be broken up into different types of surgery. There's tumor surgery, there's trauma, there's infection, but which is rare, by the way. Infection and tumors are pretty rare. They're not that common. I'm making an incision 4mm in the skin in the front of the neck. Take that. Before I do that, everyone take a look. Can you see this incision, Diego?
Yes, we're seeing it.
That's a 4mm incision, virtually bloodless surgery. I'm going to bring this dilator down over the guide wire. And I'm using the guide wire because I know that the path of the guide wire is safe. And I know it's safe because the way I placed the needle, I did it in such a way as to create a safe passageway. It's only about 1 millimeter wide. And over here to the side is the carotid artery, the carotid sheath with the jugular vein and the vagus nerve, and then over here medially is the trachea and esophagus. So I'm going between the trachea and esophagus, the carotid sheath and its contents laterally. And I'm using the dilator to spread tissues. The only bleeding we have is from me sticking the needle in to put the numbing medicine in the skin. Now I'm going to bring this dilator tip down to the front of the spine. And as I'm doing this, I'm twisting so that it doesn't grab the guide wire and drag it with it. All right, I'm going to need to get a lateral view in just a moment. I can actually feel the front of the spine. Okay, let's get a lateral view. Everybody in position. I'll need your help, doctor, for just a few more minutes while I get everything into final position to do the surgery. Perfect. That looks amazing. All right, so this thing is a little bit high in the disc at the front. Let's get an AP. Good. Relax. Let's get an AP. All right, good. So you see the spinous process at the tip there? That spinous process is in the middle of the spine, and we're just on the edge of the spinous process. So we're in a safe zone. We're just to the side. All right, go back to a lateral. So basically, we're entering the top of the disc, which is fine based on the lateral view, and we're in the center just to the left side, which is fine. You don't want to be any further to the side than we are. And let's see if I can advance this. I will need some help, guys, with the fluoro until I get everything in the final position. Doctor, if you don't mind giving us some inline traction.
Ready, doctor? Ready. I'm ready.
Shot. That's perfect. Yeah, that's perfect. Let's relax. Right there, shot. Good. And I'm going to advance this into the disc. As a matter of fact, I'm going to use the mallet to do so. Shot. Come south a little bit so we can get more penetration and we don't have to pull so hard to see. Is that the best penetration you can give me? Shot. So Diego, as I say shot and we take an x-ray shot, you're going to be getting, you're going to be switching to the x-ray shot, okay?
That is, yep, that is right.
Yeah, make sure he sees how to do that.
Yeah, he's doing it.
All right, so I need better visibility than that. Now, Monica, you showed me better visibility earlier. Shot, what happened to that? That's good, right there. All right. Shot. Almost there. Shot. Perfect. Relax. Everyone relax. Good. We've got one more step to do. So far, I want you all to understand this patient is sterilely prepped and draped. The surgery is a sterile surgery. It's done outpatient. We don't go to the hospital, but we also don't want an infection. So we do sterile prep and drape like a real surgery. We've made a 4mm incision in the front of the neck on the left side because we're targeting mainly right arm symptoms. I always like to go on the opposite side. Now, I've put a needle and through the needle a guide wire and then over the guide wire the dilator. The dilator doesn't do any damage to any of the tissues in the neck as long as it's applied properly, which I do. Now I'm going to do the whole surgery through this little metal tube. Can you guys see this tube? Diego?
Yes, we're looking at the tube.
Need you guys to respond, otherwise I don't know if you can or can't.
Yep.
All right, so this tube is like a coffee straw. The whole surgery is done through this tube. Now this is going to replace all the degenerative surgeries out there someday. There won't be a need for fusion anymore or artificial discs. And the companies that make fusion metal and artificial disc, they don't want this surgery catching on. That's why they've done everything they can to keep you from knowing about it. Because this is being done all over the world, in China, Korea, Germany, but just not the United States because the profit margins are so high for metal implants in the United States. They don't want to lose those billions of dollars. But you, the patients, are suffering through unnecessary fusion surgeries, unnecessary artificial disc surgeries. Now, this surgery isn't for everyone to do. Not every spine surgeon will be able to do this surgery. It takes tremendous amount of skill and experience, and it's not like you can learn it on a weekend course. So eventually this is what will be done for all herniated discs, bulging discs that are symptomatic, all degenerated discs as well. All right, so I'm going to need another lateral view. Yeah, this is the last time we'll need it, but I do need to advance the tube. I could feel it going in.
I'm ready.
Beautiful. You guys are doing amazing. Shot. I want to watch the end of my dilator to make sure it doesn't go in any further. I'm advancing my tube through the disc. This is perfect. Shot. Just about there. And shot. We're there. All right. Relax, everybody. So we are now at the back of the disc at C6-7, the bottom disc in the spine. Which discs get herniated in the neck? You get C5-6 is the number one. C5-7 C4-5 is number 2. C6-7 is number 2 most common. C4-5 is the 3rd most common. C3-4 is the 4th most common. So almost all the surgeries that I do for symptomatic herniated discs are at C5-6, and then a lot of times it's either C4-5 or C6-7 as well. But C5-6 is by far the most common. And that has to do with the location of the disc biomechanically with the spine. But this is not something that I've discovered. It's something that pretty much most spine surgeons that do a lot of spine surgery, they already know that. It's been published. I also published it as well in my work in 2012 and 2013. By the way, for those of you who've been following the Deuk laser disc repair, we were just published in a new book on contemporary endoscopic cervical spine surgery that just came out this year, 2021. And the Deuk laser disc repair is highlighted as one of the best endoscopic surgeries using a laser. It's in the first chapter of the book. If you pick that book up from Amazon, the title, I believe, is Contemporary Cervical Endoscopic Surgery, Spine Surgery, something like that. I have to get the actual title. Don't hand it to me then. No. All right. I'll find out the title of the book and we'll post it, or we'll post a link to Amazon where you can buy it if you want to learn about contemporary endoscopic spine surgery. Most of the surgeries are not done in the United States. Unfortunately, they're done overseas in other countries that are picking up on endoscopic technology. They're not as corrupted as the United States spine surgery field is. All right, so we're going down the tube. At the back here, we have the tear in the back of the disc with the herniation. So I need to focus the camera so we can all see a little bit better. Give me a moment. There's the focus. Beautiful. Now, because we live stream, we're able to take questions during the surgery. So if you have a question, type it up and I'll answer it for you. We have a new videographer working with Diego. Why don't you introduce him, Diego? Because he's going to be taking your place, obviously, when you head back home.
Yeah, we have a new videographer here in the conference room. His name is Brian, and is really excited to join the team.
Welcome, Brian. Brian will be doing our broadcasts going forward. We're actually very lucky that we're able to broadcast today because it's the holidays and a lot of people are out. All right, so there's a chunk of herniation down there that I just freed up with the laser. I'm going to go grab it and give it to Luis. We'll send these chunks of herniation off to the pathologist so they can look at it and verify that it's just degenerative disc and not anything else more serious. I was talking earlier about the different types of spine surgery that are done, and by far the most common is degenerative spine surgeries for herniated disc, degenerative disc, and bulging disc. That comprises about 90% of spine surgery done in the United States. And all of these degenerative problems come from trauma, some type of trauma to the disc. So people with herniated discs, those are traumatic injuries. They're not normal. They don't happen with aging. I have lots and lots of patients that are 80, 90 years old that have normal discs. That's because it's not part of the aging process to have a herniated or bulging disc. It is not normal. It's from trauma. Now, people need to understand that. I think that's one of the biggest myths in this industry is that herniated discs, bulging discs they're normal, they're expected with aging, but they're not normal. They're always traumatic injuries. Whether they need to be treated or not, that's a totally different story. Not all herniated discs need to be treated. They're only the ones causing symptoms. The problem is most doctors don't know the symptoms that herniated discs cause. They think they know all the symptoms, but they're focused on arm pain and numbness and tingling and weakness. Arm pain, numbness, tingling, and weakness. But that's not the only symptoms herniated disc cause. The most common symptom a herniated disc causes is neck pain, if it's in the neck, of course. If it's in the lower back, it'll be back pain. However, most surgeons don't know that. Man, this irrigation is cold. It's like freezing my fingers. It's good. It's good. I'm just looking at the IV tube. It's turning white. It's frosty white.
I had it in the snow.
In the what?
In the snow outside.
You had it in the snow, in the Floridian snow, huh? Right. So for those of you who don't know about Deuk Spine, we're located in the Space Coast of Florida, right near NASA, and right near SpaceX. And Blue Origin now has a rocket facility here. I think their building is 500,000 square feet. It's huge. Has anyone seen the Blue Origin building over in Titusville by NASA?
Yes.
Yeah. And how big is that thing? There's a herniation, by the way. I think it's 500,000 to 1 million. I think the new building, the two buildings together are about 1 million square feet, or pretty close somewhere. Yeah.
They're not actually on Kennedy Space Center. They're right at like the.
They're in the commerce area.
Yeah. So you can
Yeah.
drive, anyone can just drive by civilians and everyone.
Yep.
Because it's not actually on.
It's really cool. They've got their own power grid, power station. Yeah, it's amazing. It's pretty disappointing, I'm sure, for Blue Origin not to get that NASA contract.
Yeah.
But for all the SpaceX fans, they had a launch this morning. I know they had 2 launches like back to back this week, right? Yeah. All right, so what I'm dealing with here is the tear in the back of the disc, and I'm cleaning up the edges of the tear. It's called an annular debridement. This is the most important part of the surgery. You cannot just go for a herniation and be done if you want to get rid of the neck pain and you want the patient's disc to stop degenerating. You have to get the annular tear cleaned up. All this stuff right here I'm zapping, that's all nucleus pulposus that has squeezed out through the tear. You can see the tear right there. And this nucleus has squeezed out through the tear, and it's literally stuck in the edges of the annulus, which is why the annulus cannot heal. That's the whole premise of the Deuk laser disc repair, is I'm going to let this annulus heal now because I'm cleaning the edges of the tear with the laser. This laser is a holmium YAG laser, holmium YAG. There's different types of lasers used in surgery and medicine, and this is literally the best for this application. The holmium YAG laser is extremely safe for the staff and the patient. It's also, I think, more expensive than other types of lasers, but it's worth it. It produces an incredible beam of energy, and it has this particular unit has a beam that creates cavitation in the liquid. Cavitation, this is all inflammatory garbage right here, junk, collagenized disc material that we need to get out. I'm looking in his foramen here. For those of you who don't know, I'm looking in the right C6-7 foramen. Okay, and I want to clean up as much of this stuff as I can. This is all scar tissue, and it's scarred up nucleus. The nuclear material is literally stuck to the dura and to the annulus tear right there. And that's causing inflammation and neck pain. That's why people get neck pain when they have a herniated disc. It's inflammation. That was discovered here at Deuk Spine Institute. I think other surgeons alluded to it in publications as well before me, that the disc is a source of pain, and that pain is from inflammation. But I confirmed it through this procedure, and that's what we treat. We're the first surgery in the world to treat the inflammation, source of inflammation in the back of the disc. How's our irrigation? All right, so more scar tissue right here from the tear. At some point, we're going to get to, this is all calcium right there. Calcium, the gold color, is calcification. That's your osteophytes, little osteophytes, baby osteophytes, all being growing up. It's like a nursery, You know, pathological tissue is like a nursery for osteophytes. We call it dystrophic calcification. And look it up in pathology books, you'll learn about it. Dystrophic calcification is when you get calcium deposits in abnormal tissue, and this is clearly abnormal tissue. A herniated disc is abnormal. So by the way, when people tell you a herniated discs are normal and they have dystrophic calcification, by definition, dystrophic calcification only happens in abnormal tissue. So there's no way the herniated disc could be normal. So, you know, that's one of the myths we want to dispel, is that herniated discs are normal. They happen with aging. They don't. They happen with trauma. And old people don't have herniated discs necessarily unless they've had trauma. And I've seen 15-year-olds with herniated discs. I've seen 12-year-olds with herniated discs. I even saw an infant, a baby, like literally a 2-year-old baby with herniated discs. We didn't do anything about it because I think there's a very good chance in a 2-year-old baby that their disc is going to heal on its own, you know. And most disc herniations do heal to the point that they don't cause any pain. This mother, though, of the baby was very concerned, and she was very astute to notice that her 2-year-old was always in pain. And like maybe grabbing the back, you know, his 2-year-old child grabbing their back. It's pretty amazing. But that child had herniated discs. So the reason why, they had trauma, obviously. So herniated discs are not part of aging. They're not normal. They're traumatic, always. And they don't always cause pain, but they usually do. And the reason why a lot of them don't cause pain is because the people with them, they modulate their activities, they restrict their activities to get rid of the pain. It's kind of like if you have a painful knee from arthritis in your knee. You stay off of it. You don't play basketball, you don't play hockey, you restrict your activities, you don't run. And then the pain gets better. But that's no way to live your life. If your back is hurting you, you don't want to restrict your activities all the time and not enjoy life or live life or work. It robs you of the quality of your life. So why is this important? Because it's fixable now. You don't have to live with chronic back pain ruining your life, running your life. You can come here and we can fix it for you. That's the dura right there. That's the spinal cord right there. And there's a hole in the back of this disc. You shouldn't be able to see the spinal cord like that, okay? The only reason we're able to see it is because there's a huge tear back here. Now that tear will heal when I'm done with this surgery. It can't heal on its own. And that's why this poor patient's suffering, because the inflammation right here is getting right onto that dura, on the spinal cord right there. See, we figure this out at Deuk Spine. The problem is everyone around the world is being lied to by their doctors, told that their pain cannot be healed, cannot be fixed. They have to live with it. There's no treatment for it. It's in their head. All that is nonsense, folks. You just need to come to the people who know how to diagnose the source and fix it. That's why we broadcast, so people can learn the truth. The truth is, pain is curable. It just takes the right team to fix your pain. And we have that team right here at Deuk Spine. Woo-wee. That's a piece of herniation right there. All right, this is C6-7, and things are going well for this patient. We've had 0 blood loss. I think we had half a drop of blood. It takes 20 drops of blood to make a milliliter. We've had half a drop, so we would literally call this surgery a no blood loss. If you get less than a milliliter of blood loss in a surgery, then it's no blood loss, really. So that's what we get typically with our surgeries. We get pretty much no blood loss with the laser endoscopic surgery. Now compare that to a fusion or an artificial disc where they get 100 milliliters of blood loss, 200 milliliters of blood loss. Look at the beautiful view. We're now looking in his left foramen, okay, the left foramen. And again, there's a herniation right there. And it's stuck down. It's stuck down, causing chronic inflammation. And now I'm releasing it. There's another herniation right there. Come on out, buddy. That is a piece of herniated nucleus pulposus. Okay, that's what we're after. But that's a free fragment. It's the stuff that's what most surgeons just take out. They just take out free fragments. What I go after is this right here, and this is what other surgeons don't take out. This is why their surgeries don't work for pain. This is why people get recurrent herniations, because this stuff here needs to heal. And if you don't do this debridement, which is only done in the Deuk laser disc repair, it's the only surgery in the spine that does it, then you're not going to have a proper healing of your disc. You're going to be at risk for re-injuring it easily with minimal trauma. All right, any questions from our audience, Diego?
No questions just yet, but we do have a viewer who's wishing everyone at Deuk Spine a very Merry Christmas and a peaceful New Year.
Thank you. We appreciate the sentiment.
So Dr. Duke, this patient was telling me that he was waiting in Korea for his surgery to have an ACDF in Canada.
Yeah.
And they canceled him because they had to stop doing elective procedures due to COVID.
Yep.
So then he researched other options.
That's so awesome.
So he can do.
And I appreciate you sharing that story with us. That's incredible. So I was just told this patient is Canadian. They came from Canada, and they were literally in the hospital going to have an ACDF at C5-6, C6-7, same disc that I'm fixing. And they canceled the surgery while he was there, saying that COVID, it was too risky in the hospital that he could get COVID. They had to cancel their elective procedures. How convenient for the insurance company, right? They don't have to pay, but they still collect your premium. Yeah. Even though all the elective surgeries stopped for a year, they still collected everyone's premium, just like elective medical care was still happening. Nobody got a break. That's how corrupt the insurance companies are. They don't care about you. They just care about your money. Anyway, we're happy that he found us as a result, and I think he's going to be really happy with his results.
I think he's like one of your number one fans. He told me he's watched so many of your videos.
Oh, good.
He couldn't even put a number on it.
Oh, good. Thank you.
He's really excited that he could be broadcasted today.
I'm so happy.
Yeah.
Listen, I'm excited for him because this is a mess back here, and he needed the surgery for sure, and I think he's going to be really pleased with the results. I've just got to be really careful here. That's fibers of the posterior longitudinal ligament right there. Beyond that is going to be potentially the dura and the spinal cord. I don't want to get too aggressive here because I don't want to injure anything like the spinal cord or nerve root. So I feel I really did a good debridement at this point. I need to just check this foramen. I can't tell. That looks like a little bit of disc material there. And I want to get rid of that and just make sure the nerve is well decompressed. It's a little osteophyte underneath. I'm pretty happy with that. I think he's going to be happy with that too. We're done here.
Lights on, please.
So, lights on. Now you can switch over to the OR, OR camera, Diego, or
We got
whoever,
it.
Brian, whoever's doing it.
Yeah, we got the oil camera.
All right, so again, this patient was going to have an anterior cervical decompression infusion. They would have had a big ugly scar. They would have had a lot of scar tissue inside their neck that you wouldn't even see. And they would have had trouble swallowing, trouble eating, and they'd have a big metal plate in their neck right behind their swallowing tube, which nobody really wants. Instead, he came to the United States, to Orlando, came to Deuk Spine Institute, where it's the only place in the United States doing cervical, anterior cervical endoscopic surgery. And we're now fixing his herniation without fusion. Deuk Spine Institute is a leader in the world in endoscopic surgery, endoscopic spine surgery, certainly in the United States. All right, at this point, we're going to move from the C6-7 up to the C5-6, okay? So to do that, we're going to reposition the fluoro, the C-arm, which is an X-ray machine, and we're going to get some views of the side of the spine. And I'm going to basically take the tube out, and then I'm going to march the dilator up to the next disc. Go ahead and go lateral. Okay, let's show the audience that tube that we just did the whole surgery through. You guys see this tube, Diego?
Yes, sir.
For the people that came in late, why don't you run the video, the animation on why people have pain in their neck, why they get neck pain and arm pain or headaches from a herniated disc in the neck. Can you run that video?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging
Excellent. Take this. Good. So right now we're going to move from C6-7 up to C5-6. So C2, 3, 4, 5, 6, 7. Everyone agree? All right, here we go. First thing I got to do is take the dilator out of the disc space, and then I'm going to march it up the spine along the ALL. There, we're out. Shot. Good. How you doing, Luis?
I'm good.
Coker. AP. So I'm using a side view and a front view of the spine. Are you okay? Just a quick shot. And I'm going to march this dilator up the spine. So I'm a little bit on my side. So I want to cheat a little bit to the middle. Relax. Just stay there. Shot. That's perfect. Let's go back to a lateral view. Since we're going up the spine towards the head, it's easier to see because the shoulders are not in the way of the x-ray machine. So we actually get a clearer picture as we move up. I'm hoping for a clearer picture and a little bit less effort on my team's part. Good, good. I'm going to march up the spine to the next disc. Shot. Shot. I'm definitely on the disc. Let's see if I'm in the middle of the disc. Shot and AP. Let's see where we are. Quick AP. He's still relaxed, right? Good. Quick AP. Quick AP. So I've moved from, there's 2, 3, 4, 5, 6. A little bit off to his side. I want to bring it back to mine. By his side, I mean Luis's side. Let's see, that should be good right there. Hold on. And I'm trying to get my hands out of the radiation. Perfect. Lateral. So that's perfectly in the middle of C5-6. I'm right on the front of the spine. I can feel it. I want to make sure on the lateral view I'm right over the disc. Now the dilator will spread the fibers of the disc. Yes, I am. Take. Shot. Perfect. So what's happening is the dilator tip is tapered, and it will literally it'll literally spread things apart. It doesn't hurt anything, except it could hurt the spinal cord or the nerve in the back if we're not careful. But I'm, of course, going to be very careful about that. But right now we're just going through the jelly in the middle of the disc called the nucleus pulposus. Shot. And I'm not hurting it at all because the nucleus is very watery. It's like swimming in a pool. Are you going to hurt the water in the pool when you dive in? No. The water just spreads and then collapses behind you. Shot. So the nucleus is mostly water. Shot. Shot. Oh, Dr. Rafferty, you can relax, by the way. Shot. I didn't know if you were still. Shot. Where do you see the guide wire? Shot. Shot. There just gets to be a little bit of schmutz in there. All right, now we're going to do our discogram. Luis, I'd like you to give me a little shoulder pull. And it's just the last time we'll need, oh, actually, probably the last time we'll need a little head pull. It's not wanting to go. Shot. I don't know if I got any out. Doesn't look like it. All right. Let's see. All right, relax, everybody. Take this. Let's get the pipe cleaner again. This disc, I think, is a bit more scarred up. At least that's what I'm feeling. Shot. The more scarred a disc is, the less likely you can do the discogram. It's all scar tissue. It's very scarred up from inflammation. This is part of the degenerative condition of the disc. Discs degenerate because of inflammation, and inflammation causes scar tissue. Shot. I felt some going in. There it is. All right, we got it that time. And shot. Nice. Everybody relax. Take that. All right. This time the dye went in very nicely. We're going to advance. No, we need to advance this dilator to the back of the disc where the tear is that we're here to fix. Shot. I can feel this dilator going in, and it feels like the disc is pretty scarred up. Now, the scar tissue in the middle of the disc that I'm feeling is not a problem. It doesn't cause pain. It doesn't cause neurological symptoms. It's just, I'm just noting it for the record, so to speak. But the scar tissue at the back of the disc is the one that causes the pain in the neck and the arm symptoms. Once again, we're going to do everything through a tiny 4mm tube. All of this surgery is FDA approved. Everything we use is FDA approved. All right, Luis, last one. You ready? Shot. So we're going to advance the tube over the dilator. It's just making the tube a little fatter, basically, or the dilator a little fatter. So, shot. Shot. Again, it's just little increments. You're working over the spinal cord, so we want to make sure that we don't have the dilator or the tube going into the spinal cord. Shot. Are you pulsing? Good. We're just about done with X-ray. I just need it for another minute. Shot. Hey, I think that's pretty darn good right there. All right. So we've got our tube in the back. Take one more shot. And we're ready to rock and roll. We're right at the tear, where the tear begins. The tear is about 1 centimeter thick. From front to back, but it's allowed the jelly from the nucleus to squeeze through the tear and wedge itself into the tear, causing all this neck pain and headache and arm pain. So, for those of you who have ever fallen asleep on your arm, you know how your hand gets weak and numb and tingly? Weakness, numbness, and tingling is typically from pressure on the nerve, but the pain is from inflammation. Pain is from inflammation. And that's what most spine surgeons don't know. That's what most of the world doesn't know. They think that herniated disc disease is all about pressure, but it's not. It's also about inflammation or irritation of the membranes. And it's totally fixable. That's why epidurals actually help people, because they're anti-inflammatory. So they're not removing structurally anything, they're just removing inflammation. But we found the source of the inflammation to be the tear here at Deuk Spine, and we treat that tear and get rid of the inflammation. All right, lasers on. Here we go. By the way, I've also been invited to speak at a World Congress in Los Angeles next year on the Deuk laser disc repair to neuroscientists from around the world. And it's, what's that? Yeah, I am the invited guest speaker to talk about cervical and thoracic endoscopic spine surgery, because I'm basically the pioneer in those two parts of the spine. I was invited by the scientific committee to speak, and I plan to attend in LA and give a talk, 2 talks as a matter of fact, one for cervical, one for thoracic. All right, so, huh? My old stomping ground, Los Angeles, yes. You know I went to USC for med school in Los Angeles, UC San Diego undergrad. But I tell you, I'm not that keen to go back there. I'm now a Florida boy, and I love the Southeast. We know there's a lot of people moving from California to Florida and Texas. They've tapped out. Huh, Luis? Okay, we are at C5-6, and again, this disc to me is more scarred up. You can still see the end plate at 9 o'clock and 3 o'clock. That's the C5 and C6 end plate. Here's a piece of herniation right there. I'm blasting it. Look at that thing. There it goes. It just came out of the space right where the spinal cord and nerve are. We call that the epidural space. I have spoke on the Deuk laser disc repair all over the world. I've been to Hong Kong. I've been to other places in the United States. I've been in, my papers have been accepted by the American Association of Neurological Surgeons, the Congress of Neurological Surgeons. They've been peer reviewed and published. At those meetings, I presented to them as well. And it's funny, despite all these meetings and teaching surgeons about the procedure, it's a very hard procedure to learn. It takes a year-long fellowship, at least, to learn how to do it. But these surgeons are perfectly happy doing fusions because they make more money with fusions. It's long and short of it. Fusions do pay better, but that's the wrong reason to be doing fusions, in my opinion. If you have this available, which again, most spine surgeons don't. They don't know how to do it. How's our irrigation? It looks like we're running a little low. Yeah. Yep, thank you. All right, we're going to be done in probably 15 minutes, doctor. So if you want to start winding down the anesthesia. Our patient is asleep under general endotracheal anesthesia. With chemical paralysis, we use, what do we use? We use what? Rocuronium. And then for general anesthesia, we're using sevoflurane. So we have a gas anesthesia. We'll probably convert the patient over to propofol from gas, or maybe just let it wear off. But we have an anesthesiologist who's here caring for our patients. And oh, look at that herniation. Another herniation coming out. Just so many pieces of herniation. And a lot of them are collagenized, meaning they've been worked over by the inflammatory system of the body. That's a big one right there. I'm going to get it out right there. Oh yeah, baby. Don't you love it when a plan comes together? So to get that guy out, I put a little pressure down on the tube to push the bones apart and open that gap at the back of the disc and get better exposure to the epidural space. There it is. All these pieces, by the way, they're only like maybe 2 millimeters to 3 millimeters. They're not huge because remember the tube is only about 3.5 millimeters wide, 3.2 millimeters wide. So the outside part of the tube is 4, but the inner diameter of this tube is around 3.2 millimeters. So a herniation that fills the tube is only around 3.5 millimeters wide anyway. So it looks big, but it's not that big. Sorry, guys. Boy, nobody catches my jokes anymore. You can say. I mean, somebody's got to laugh. I said, sorry, guys. All right. So there's the crack between the bones. That's where the spinal cord and nerves are down there. All right, let's rotate. Any questions from our audience, Diego? I wonder if people knew we were going to broadcast today because you were out sick and we really didn't, publish a schedule.
No questions so far.
Is that Brian?
Yes, sir.
All right. How's it going over there?
It's going well. Interesting stuff.
Good. All right, so why don't you run the animation on the Deuk laser disc repair cervical spine so our audience can see exactly what we're doing here. The animation will explain step by step what we do.
Disc herniation
All right,
is a
Dr.
common
Deuk.
cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain,
One.
Well, I hope you had an opportunity to see the video animation that we created. That was created by Zach when Zach was working for us. And I think it's a phenomenal explanation of what we do here. You can see that we make a small incision in the skin. We basically use a little tube to get down to the back of the disc where the problem is. And that way we can preserve the front of the disc so that we're not removing the front of the disc. We're only removing the little thing in the back causing all the pain and symptoms, which is the herniation and annular tear. There's another herniation right there. Beautiful. Look how scarred up it is. It's so white and dense. That's from scarring. These tissues are normally not white and dense. They're normally very fluffy and soft. See that golden color? That's dystrophic calcification. That's the beginning of bone spurs. That's kind of an osteophyte right there. People always ask me, can the laser remove bone spurs? Absolutely. Lasers cut steel, folks. The Homium YAG laser is no different. We have this laser on a setting of 20 out of 100. And it's still cutting through this hard bony material. So imagine we're at 20% power right now. Imagine if we went up to 100. We could literally blast holes in the bone. So bone spurs are nothing for a laser, a good laser. Now, of course, that depends on what kind of laser. If the doctor's using a gimmick laser, they're not going to go through bone spurs. But a real laser, a real surgical procedure like the Deuk laser disc repair, our lasers can melt steel. And they do, by the way, melt steel. They melt our own steel. If you look at the wall around this tube at the end there, see all that dark discolored stuff? That's from laser blasts melting the steel. That's melted steel, surgical steel down there. Okay, so absolutely we melt steel. I'm not trying to melt steel, but you know, sometimes the jiggling of the laser, it jiggles against the sidewall of the tube and it causes that steel to melt. Things are starting to look good. We're just about done. I think 5 more minutes. You see how this thing is so hard to get out right here? That's because it's calcified and scarred up. There's still stuff in that foramen I'm going to have to get out. All right, so I need to get a little more lateral into the foramen. Any questions from our audience?
Just Merry Christmas, Doctor, that's all.
What's that?
Just Merry Christmas.
Oh, that's really kind. All right, there's a big herniation there. I got to go grab it out. So you see how the surgery is a combination of laser debridement with removing larger pieces using the grabbers. That's a good size. That one was about 3 millimeter by 2 millimeter. Just a few more minutes, guys and gals. And our next patient is ready already. We'll be coming in here, right?
Yes, sir. Yes, sir.
So you'll get everybody to help you turn over the room.
We have a battalion.
Huh?
We have a battalion.
A battalion, good. Colby, how are you doing? Huh?
Kobe. Great.
Good. You like being in here? All right, good. Well, as long as you work hard, you can stay and be part of the team. Just about done. I just need this last little piece over here. There's a lot of maneuvering, by the way, of the surgeon. Maybe some of you have seen me dance in the operating room, but I have to move my body just to get the angles I need to get this stuff out. It's not easy because the patient's chest is, you know, people have a chest and the chest is up pushing against my hand here as I'm going in. So it's not easy for me to do this. And that's why I move around a lot. I try to leverage my weight. This is not a just stand in one place kind of surgery. It really requires that you dance around the patient. Again, we're saving this patient from a fusion. He was slated to have an anterior cervical discectomy and fusion done in Canada. Do we know where in Canada? Ontario? There you go. All right, I think we're just about done. All right. And once again, he canceled his ACDF. They canceled him, and then he canceled them. And now he's here, having laser instead. Far better surgery. Deuk laser disc repair. All right, definitely 3 minutes. Lost my laser fiber. By the way, for those of you who don't know, at 12 o'clock, that is the laser fiber. And that transmits energy from a machine in the operating room, a special piece of equipment called a laser, holmium YAG laser. It produces a laser energy, and that laser energy transmits along this glass fiber to the tip, and I basically direct the laser energy where I want it to go. I use a straight firing laser. And just to give you an idea, for those of you who don't know, the differences between what I do and what the South Koreans do. I learned the approach from the South Koreans. The approach means the needle, the guide wire, the dilator, all that stuff the Koreans taught me. However, the technique of debridement of the annular tear is my technique. Also, I put patients to sleep. They don't. At least they didn't years ago when I learned. They would have the patient awake for surgery. And the patients were squirming around during surgery, and it was crazy because it's so risky. Could easily injure their spinal cord with all that movement. So I decided, hey, let me put these people to sleep so they don't move. And I've never had an injury to the spinal cord or to the nerves as a result of that. This is just scar tissue on the dura. We've cleaned up 90% of it. One thing you don't want to do in this spine surgeries is gild the lily. The lily is beautiful enough, you don't need to gild it. Get what needs to be done, and don't go too overboard. Going overboard only causes problems.
Cup off.
You can get complications from going overboard.
Cup off, please. Lights on, please.
We're done. I'm going to show you the whole surgery is done through this tiny little incision. We're going to put a little antiseptic down called betadine. Questions from the audience?
Yes, we have a question from Facebook. Do you grade what you find during operations so that you can analyze the actual damage and continue research?
I couldn't hear the beginning.
Okay. We have a question that says, do you grade what you find during
Oh,
operations?
Do I grade what I find? No, I do not. So it's a great question. Whoever asked that question. I would love to do more research, but the truth is I just don't have the time. I'm so busy running this business and trying to help people that the research side I don't have time for. There is literally, I could publish 50 papers with all the surgeries we've done and the discoveries we've made during these surgeries. I just don't have the time to do it. I need a research assistant. So it's a great question. I think it's a really good point to do that. Let me just show you guys before I take this all the way out what we did here. But I just don't have time to do it. But we do have obviously all the video. So, all right, chin is here, face is here, tube is coming out of the mouth. The patient's asleep. We're waking him up. This is the chest, left side of the neck. We had 0 blood loss for the surgery, no blood loss. And the whole surgery is done through this little metal straw. Now we may get a drop of blood here when I come out. I'm going to apply pressure. So one of the reasons we don't have blood loss is we're not making a big opening. And this type of surgery, when you do an ACDF or an artificial disc, you got to dissect tissues. You got to cut tissue. You got to cut muscle. All those tissues bleed. Veins bleed. So unless we accidentally hit a vein, which is so rare to actually hit a vein with the needle, we're not going to have bleeding. And if you get a little bit of vein bleeding, you just put pressure and it stops. I don't know if we got a vein or not, but I just put pressure anyway. It's the safest thing to do. I don't want to have a blood clot forming. So that's it. I mean, the surgery's done. No metal, no fusion, no artificial disc, all natural. We repaired the disc. Take a look at the incision. That's it right there, 4 millimeters. The whole surgery was done through that incision. I'm going to have to call it, 0 blood loss, basically. Thank you, everybody. Great job. Thank you for keeping our room warm. I'm just kidding. I know they're giving you gradual responsibilities, right? That's good. Always pay attention. Watch what people are doing, and you can learn. And the more you learn, the more helpful you are. Thank you, Monica. That was a tough one with that neck.
When I was doing that lateral, that's what happened. The handle came right off and I couldn't do anything with it. So I'll have to,
I think this comes off, and then there's a little wrench in there that can tighten it. Yeah, Luis, tell Luis to have a look at it. But I think you can pop that green thing off. All right, I'm going to answer questions for you all. I'm heading over there right now. So type up your questions, and I'll come and do a post-op debrief. Why don't you run a little Testimonial for them. I have a very special patient sitting here next to me who's traveled all the way from Tennessee
Yes, sir.
with his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, no, come, is, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated disc, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so
All right,
much.
so we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery, when I talked to her, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. From the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. When we walk into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome. All right, Dr. Deuk, we've just wrapped up a anterior cervical Deuk laser disc repair, only performed here at Deuk Spine Institute, but peer-reviewed and published around the world. This surgery is an endoscopic surgery. We go through the disc in the front of the spine. Just to give you an idea of what it is we're doing, let me show you this model right here. So if you look at the model, you can see there's a bone and a bone. And then you got this red thing here, that's the disc. At the back of the disc right there is a herniation. Let me turn it the right way here for you. That herniation is where the patient's neck pain's coming from and the arm symptoms. So surgeons want to get to that herniation. Typically we do an ACDF or an artificial disc. That's been the standard of care for years. And we would go in and take this whole disc out just to get to the piece in the back. Once you've removed the disc, there's nothing between the bones but air. So you got to put a cage in there and a metal plate to hold it together, or you put an artificial disc. So what the Koreans started doing, and there's some history to this years ago, this is back in the 90s, was the Koreans figured out they could actually go through the disc with a tiny tube, get to the back and zap out that herniation, unpinch the nerve. And I learned that technique from them shortly after they discovered it, like literally within a few years. I went over there and learned the technique from the leaders in the world that were doing it. And then I brought it back to the States. I made my own changes, made it better. And it's better because it has better results than their surgeries. And we're able to actually cure neck pain and headaches that come from the herniation, as well as the arm symptoms. So that's what we did. We went through the disc, left the rest of the disc alone, got to the back, and I just zapped out the herniation, and I debrided the annular tear. The annular debridement is the most important part of the surgery. It's done with a laser. And again, I'm the only one in the world doing it right now at Deuk Spine Institute, and we're the only ones getting basically 100% success rate at eliminating neck pain, headaches, and arm symptoms from the herniated disc. You were able to see the animations to explain exactly what it is I'm doing, and also you saw a testimonial as well. Do we have any questions to answer?
Yes, we have a question from our mobile app. It comes from Rob. And
Hello, Rob. Happy holidays.
He's asking, how many surgical procedures do you do a year? And how long is the waiting list?
Well, Rob, from the mobile app, again, and just to remind you, Deuk Spine Institute does have an app. It's free. You can download it onto your phone. We have an Android version, and we have a Apple version as well. And the app is wonderful for exploring the latest in diagnoses with conditions of the spine, as well as some treatments that we recommend that are more advanced treatments. All right, so how many surgeries do I do a year? Honestly, I don't sit there and keep track of it, but I just do what comes. We have kind of times when we do more and times when we do less, but I average probably around 200 surgeries a year. Certainly there are spine surgeons that do a lot more than me. You know, I don't ever say that I do the most surgeries because I don't. I probably am on the bottom end of the bell curve in terms of sheer number. However, the quality of our surgeries is remarkable. There's nobody in the world that has outcomes like we do. This patient you just saw is going to go home in 30 minutes to an hour. And they'll come back in for a quick checkup tomorrow morning for 10 minutes. Maybe we'll shoot a video testimonial before they go back to Canada. But basically our recovery times and our success rate at eliminating pain is nobody even comes close in the world. These surgeries are done outpatient. Most ACDFs and artificial discs are done in the hospital. So people stay in the hospital for a couple of days. These are done outpatient. There's no time lost. Literally, this patient will be walking the beach later today with his wife. So the recovery is much better. Our patients don't get narcotics. They don't get painkillers. There is no need for it. They take Tylenol and maybe a muscle relaxer, and that's it. But these surgeries don't require narcotics or opioids. So there's no risk of getting addicted from the surgery because we're not going to be giving anybody any narcotics. They just don't need them. And then, you know, just be able to wake up from surgery and not have that pain anymore is pretty remarkable. And that's what our patients experience. So it's about quality, not quantity. But I do about 200 spine surgeries a year. I could do more. Oh, absolutely. I could go and take call at the hospitals and be on call more often and, you know, make myself more available. But I'll be honest with you, a lot of my work is administrative work, trying to keep Deuk Spine going. And that takes a lot of my time. So I would love to free up some of my administrative duties if you want to come over and help us out. We are hiring, and then I could do more surgeries. But I appreciate the question. I think I answered it, right? Are we done?
And that is it.
All right, we'll be back in about 30 minutes with another surgery, pretty much another cervical Deuk laser disc repair. I think it's 2 levels, 1 or 2 levels. I got to go check. But today we have a treat. We have 3 cervical Deuk laser disc repairs and 1 lumbar. So we have a full day of broadcasting for you. Have a wonderful day, and